You're welcome, everybody. We'll get started in just a minute. Just wanted to let people in from the waiting room.
All right, we'll go ahead and get started. Hi, everyone. This is Lola. I'm the coordinator of the Harvard and Beth Israel Deaconess Medical Center site for New England MHTTC. Please feel free to introduce yourself in the chat box if you'd like. And now I just want to review a few housekeeping items before we begin. Next slide, please. Jean, do you mind moving to the next?
Sure. Sorry. There you go.
Yeah. So participant microphones will be muted at entry and you'll be able to unmute them during the discussion portion. If you do have any questions during the event, either technical or content related, please use the chat. This session is being recorded and it will be emailed out to all participants once it becomes available and posted to our website. If you have questions after this session, you can email newengland@mhttcnetwork.org. At the end of the month, we send completion certificates that you can submit to your particular board for continuing education credit. If you have any questions about CEs, please contact ifisher@c4innovates.com for more information. Next slide, please. These are some MHTTC acknowledgements. Next slide. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and lastly, consistent with our actions, policies, and products. And with that, I'll hand it over to Kelsey for some introductions.
Sure. Yeah. Thank you so much, Lola. So great to see so many people here. I think it speaks to really the importance and relevance of the topic that we have today. So this really came out of actually conversations that we've had with clinicians in our psychosis programs here in Massachusetts. These questions around diagnosis and treating psychosis when autism spectrum is a part of that picture. So what are the kind of specifics to that presentation and how can we best be supporting those clients? So very excited to have Dr. Fraser here today with us to talk about this topic in more depth. I think she has a great background to be presenting on this. So I will hand it over to Raquel Meshlam-Gately from our group to introduce Dr. Fraser.
Thanks so much, Kelsey. So it is my absolute delight to introduce Dr. Jean Fraser, who I had the pleasure of first meeting around 15 years ago when we collaborated on a research project. I very quickly realized that she not only was a wonderful researcher, clinician, and educator, but an incredibly kind, down-to-earth person as well. So when she agreed to present today, I was absolutely thrilled. So I'm just going to give a very brief introduction for Dr. Fraser, because if I spoke about all her accomplishments, we'd be here a very, very long time. Dr. Fraser is the executive director of the Eunice Kennedy Shriver Center at UMass Chan Medical School, which is devoted to supporting, empowering, and including people with autism spectrum disorder and those with intellectual and developmental disabilities in the community. In addition, she is the Robert M. and Shirley S. Siff Endowed Chair in Autism and tenured professor of psychiatry and pediatrics. Since 2020, she has been the medical director of the Massachusetts Child Psychiatry Access Program for those with autism and intellectual and developmental disabilities. She is the founder of the Center for Autism and Neurodevelopmental Disorders clinical program. She has 3 decades of clinical and research experience in working with individuals with autism spectrum disorders who have comorbid psychiatric conditions, most especially bipolar disorder and schizophrenia spectrum disorders. Dr. Fraser has published 185 peer-reviewed journal articles and 30 book chapters. She is a highly sought-out mentor and teacher and has won numerous awards for her teaching and mentoring, including the Outstanding Educator Award for Mental Health Education from the New England Educational Institute. So with that, and without further ado, it is my great pleasure to turn things over to Dr. Fraser.
Well, thank you so much, Raquel. It's my delight to be here, and it's so nice to see so many people. This is really a topic near and dear to my heart, and clearly it's taken the world by fire, if I must say, because I've gotten so many more questions about the diagnostic overlap, I would say over the past 5 years, and have increasing number of referrals. So I'm really happy to be here to share what I know on this topic, and certainly look forward to learning from you all too. My hope is, as we progress with the webinar, that you all think of questions. There will be time for Q&A at the end, and certainly if you have some pressing questions about cases, I look forward to trying to field those as well. Before I get started, not only am I a clinician and an administrator, but I do research, and I just wanted you to know we are part of the Autism Cares Network through Autism Speaks. We do some clinical trials right now. We're engaged in 2 of them. Those trials are focused on Fragile X syndrome, the Helix one and the Tetra. Also, we have several grants to the NIH, and we're involved in a biomarker study that's focused on autism. So I hope by the time we finish, you guys will be able to do the following. I'd love it if you could understand what is known about autism and psychiatric comorbidities in general, have a systematic approach to the diagnosis of psychosis in autism, and recite the recommended approach to treatment of psychosis in autism. And before we get started, I actually have a couple of polls. I'd like to ask you all a few questions before we get started. So the first question is, do you primarily work with adult clients or child clients? Okay. So it looks like, can we share the results?
Yeah, they should be up. From
Up.
what I'm seeing right now, we have about 28 primarily child and 72 primarily adult. And some in the comments saying with both. So.
Great, that's wonderful. Well, a lot of what I'm going to present is rooted in some child data, because autism is, starts in childhood, but it's all relevant. And I'm delighted there are so many adult providers here, because one of my passions is to equip our adult providers with knowledge of evidence-based, treatments for folks with autism and IDD. So that's wonderful. Okay, for the second question that we have is, have you had experience with a patient who had psychosis and autism? Yes, no, or maybe. Okay, that's great. So good majority of you have had experience, about 70%, 8% haven't seen patients with this comorbid presentation, and 23% of you fall in the sort of conundrum area. And that is also important to note too, because the overlap between the two is often very confusing. So thank you for sharing that. Okay, and we can stop the poll now. Terrific. let's move on. All right, so I'm going to start with a little journey through our DSM, just to give you a framework as to why, I mean, historically, the division between the two diagnoses and the overlap is clearly reflected in our DSM system. So way back in DSM-2 in 1968, schizophrenia, the childhood type, actually, interestingly, involved mostly children with autism. And if you just read the text, this category is for cases in which schizophrenic symptoms appear before puberty. The condition may be manifested by autistic, atypical, and withdrawn behavior. And I just really want to highlight that they characterize children with atypical development and withdrawn behavior and basically autistic traits as having schizophrenia. And for those of you who might know the literature that dates back to 1960s, the literature, if it's talking about childhood type schizophrenia, most predominantly the children enrolled in those studies or described in the literature all had autism. So in 1980 in DSM-3, based on the work of Colvin and colleagues in the early 1970s, we actually distinguished autism, and back then it was called PDD, or pervasive developmental disorder, from schizophrenia. They were two separate diagnoses. So at the time we had PDD, or pervasive developmental disorder, and that condition involved a variety of different hallmarks, including excessive anxiety, constricted inappropriate affect, resistance to change, oddities of motor movement, abnormalities of speech, hyper or hyposensitivity to sensory stimuli, and self-mutilation. And the onset had to occur after 30 months of age and before 12 years, and required the absence of delusions, hallucinations, incoherence, or marked loosening of association. And here it is from DSM-3R 1987 under schizophrenia. In the text for schizophrenia description, it says schizophrenia occurring in a child preempts the residual diagnosis of PDD-NOS. In other words, if a child had autism before they developed psychosis, once they developed psychosis and were diagnosed with schizophrenia, then the autism diagnosis would go away, which at the time was a real problem because most of these individuals who had schizophrenia also continued to have features of autism or PDD. And unfortunately, I'm old enough to know that once that PDD diagnosis went away, these individuals lost access to all the autism-specific services that previously had been available to them, which was a real problem from a clinical perspective. So come DSM-4 in 1994, and then DSM-4-TR in 2000, things got revised yet again speaking to the conundrum here. So the relationship to PDD, which is now known as autism, under schizophrenia, if there is a history of autistic disorder or another PDD, the additional diagnosis of schizophrenia is made only if there are prominent delusions or hallucinations for at least 1 month. So we moved from DSM-3, where you couldn't have both disorders diagnosed at the same time, to DSM-4, where it actually allowed the diagnosis of schizophrenia and autism, which was a blessing from my perspective as a clinician, because the individuals who had psychosis and autism continued to be able to access both the treatment for schizophrenia and the treatments available for autism. So for those of you who don't know, the CDC just came out with its new prevalence in the last couple days. So the prevalence of autism now, as of 2023, is 1 in 36 children. That's huge. It's 2.8%. The last figure was 1 in 44. And when we first started collecting the data on the prevalence of autism in 1987, it was 1 in 2000. So it is increasing in prevalence with every time we look at the data. And one of my colleagues is fond of saying, we have a tsunami wave of individuals with autism in our community. And it's all the more reason that we need to have webinars like this to equip not only child providers, but adult providers for what's coming. Now, what is autism? Well, I think of it as an exemplar of neurodevelopmental disorders. It's these individuals have restricted, repetitive patterns of behaviors or interests or activities. For example, they get interested in things like train schedules or Beanie Babies, I've got, or Pokemon cards. They have deficits in social communication and social interaction. And generally speaking, they have really poor outcomes in social functioning. And these poor outcomes really are reflected in the fact that individuals with autism have difficulty maintaining adult functioning roles. It's very difficult for many of them to hold on to jobs, in large part because they have problematic social interactions. Equally important is for those who do have jobs, often their skills are underutilized, and also they typically are paid below minimum wage. Unfortunately, we don't have any current medical therapies available to us to target the core social communication deficits in autism. Now, again, let me share some statistics with you, which is the male to female ratio generally is about 4 to 1. And for those of you who know the childhood onset schizophrenia literature, which means these are kids who have onset of classic symptoms of schizophrenia before the age of 12, those individuals have a male to female ratio of about 3 to 4 to 1. As I said in the last slide, as of just yesterday, the CDC released the new data, and autism occurs in about 1 out of 36 children. Again, that's about 2.8%. The prevalence has been increasing over the years. You can look back to 2000 and eyeball this prevalence graph to see how much it is increasing and how steep the curve is. And why do we have the increased prevalence? Well, it's probably for many reasons. First of all, we've reclassified things in the DSM. We've got better diagnostic methods, especially within lower and higher IQ children. We have better population sampling, and there might be some connection to environmental exposures, which is an area of increasing research. So for those of you who know individuals on the spectrum or you've worked with them, there's a wide range of intellectual level. There's a wide range of communication ability. We've got folks who are nonverbal all the way up to people who are hyperverbal. There's a wide range of behavioral challenges. And, I like to say, if you've seen one person with autism, you've seen one person with autism. They're like snowflakes. They're very, very unique in and of themselves. And I think part of the problem we're facing is, with the increasing prevalence, we're going to be presented with more and more individuals in our outpatient adult clinics and inpatient units who actually do have autism. Depending on the literature you read, 75% of individuals with autism require treatment for emotional, physical, or behavioral problems. Approximately 70% of people with autism have at least one psychiatric disorder, and about 40% have at least two comorbid or co-occurring psychiatric conditions. And I can tell you, this is really one of the most challenging disorders for families and providers. It's not unusual for people to come to me to say, Dr. Frazier, I know my child is in there. Please, please help me find him. We know that there's quite a bit of expense involved. For a single person with autism, it costs about $1.3 million across the lifespan to care for that individual. And if you add in an intellectual disability on top of the autism, the cost goes up to about $2.4 million.
And
All right.
Dr. Frazier, I just want to point out a couple things from the chat. First one from Susan Gingrich about there's an article, it seems this morning in the New York Times about this increased rate of autism. So it's just 1 out of 36. So really interesting to see this kind of information shared in a major newspaper. And another comment about wondering how accurate the gender divide is given the differing presentations, kind of to your point of, if you've seen one person with autism, you've seen one person with autism. So wondering if you can comment on one or either of those.
Yeah, well, I think the New York Times, you're going to see a lot of articles in this regard, actually in the next coming days. And that's because the CDC just released this information. Every time the CDC releases this information, there are articles that are published, and it's interesting because we've done a good job actually in increasing our early diagnosis. And also another thing that's hot in the field right now, and it has been, is the inequity or to access to care. And so historically, Black people in our community and Hispanics have not had ready access to diagnosis, and the prevalence rates in those populations has been less than in the white population. But this year, actually, the prevalence of autism in the Black community now exceeds what we find in our white population, and that is also true in the Asian populations. So I think there's some good news in that statistic, in that we've gotten better at increasing access to care and to diagnosis. And what was the second question? I'm sorry.
Speaking to the gender differences in
autism.
autism.
The gender difference. This is an interesting area of research, actually. And I think there's a meaningful and true gender difference, in part because most neurodevelopmental disorders tend to present more frequently in boys than girls until various populations reach puberty. And, again, we can speculate on why that might be, whether it's hormonally based or some other reason or multi-complex reason. But I do also wonder if the gender difference may be less than the statistics report, because girls often have a milder presentation. And so I think that we need to do more research in this area. Any other comments or questions at this time? Okay. So I put this slide in here specifically because, again, autism is not just one thing, and autism with its behavioral challenges is not just one thing. And most often it's kind of like a Venn diagram. You have autism in the middle, and then you have all these symptom complexes circling around with some overlap. And again, for years I ran the childhood psychosis program at McLean Hospital, and had about 300 outpatients. And some had schizophrenia, some had autism, some had bipolar, some had, at least 2 of those comorbidities. But the typical question when folks come to a clinic like mine is, Dr. Frazier, can you help me? Does this child have autism? Is there ADHD? Does this child have a mood disorder, anxiety, obsessive compulsive disorder? Oh, and Dr. Frazier, is there a thought disorder involved here? So for those of you who know the good work out of Kaiser Permanente, Lisa Cohen and colleagues published a series of articles about 7 years ago now, looking at the health status of adults on the autism spectrum. And they had thousands and thousands of individuals who had autism, and about 10 times the number of adults who didn't have autism as a comparator group. And as you can see, the prevalence of psychiatric conditions in adults with autism versus adults without autism it's huge, the difference. If you look here, anxiety disorders occur in about 27% of adults with autism versus about 7% in those without autism. But pertinent to today's talk, if you look at bipolar disorder in that particular data set, about 10% of those with autism had bipolar, and approximately 2% in adults without autism. And then go all the way to the other side of the slide, 8% of adults with autism had schizophrenia, as opposed to 1% in adults without schizophrenia. So let's talk about autism spectrum and psychosis. Here's the nature of the problem, and this is why we all struggle with this. The core features of autism spectrum disorder can be misinterpreted as psychosis. And just that whole nosologic journey through the DSM history speaks to this. It's a conundrum. And if you look across epidemiologic literature, clinical literature, neurobiologic literature, and genetic literature, there is evidence for a connection between autism and schizophrenia. There are some differences as well, but there is a fair amount of overlap. In addition, we have a subset of complex neurodevelopmental disorders with symptoms that across multiple domains of functioning. Gay Carlson and I used to call them the diagnostically homeless children. They have varying degrees of social communication deficits and thought disorder. So what do we know about the comorbidity between autism and bipolar disorder? Well, there have been a variety of studies over the past 2 or 3 decades, but one study was published by Janet Wozniak from Mass General in 1997, where they looked at the children with autism and found that 27% of those children with autism in this particular paper also had bipolar disorder. They also found, conversely, that 12% of all children in the overlap sample, 12% who had bipolar disorder, so also represented 12% of all the children who had bipolar disorder. So let me explain that again. 27% of the children with autism also had bipolar disorder. And conversely, if you looked at the children who had bipolar disorder in that sample, 12% of those children had autism. Now, there have been a number of different studies. Again, Hirschberg in 1996, DeLong in 1994, they found that youth who had autism and a family history of bipolar disorder compared to those who did not have a family history of bipolar disorder had extremes of affect, cyclicality, intense obsessive interest, neurovegetative symptoms, and regression. Joe Piven also looked at children with bipolar disorder and quantified how many of them had a family history of mood disorder. and found that a third of those children had a family history of mood disorder. And another study by DeLong found that in children with autism, about 12% of them had a positive family history of bipolar disorder. So if you have a child with bipolar disorder and autism, the symptoms of bipolar disorder may be masked by symptoms associated with autism. And what I can tell you is that sometimes the baseline behaviors that we see in children with autism, once they become manic or have a mood episode, those baseline behaviors may become more intense or exaggerated during a manic or depressive episode. The key here is to look for a distinct change from baseline and for episodes. So let me give you a case example here, and this is a true case. When I was working at McLean Hospital, a mother brought her teenage boy in. I think he was 15 at the time, and she said, "Dr. Fraser, the school just doesn't seem to be able to manage my son. There's something wrong. He's very different. And he's winding up in restraints all the time. And they think it's just a behavioral issue." But she said, he's different. He's different. So when we were doing the initial diagnostic and I saw him, he was high functioning, had very rapid and pressured speech. And when I got a history from mom, she said, "Well, he's always been interested in water and soap, but it's gotten to be, a different pitch. Dr. Fraser, he's up all night. He's emptying all the drawers from all of our rooms and taking clean folded clothes and putting in the washing machine and washing things and rewashing things all night long." And she said, "It's getting to be ridiculous. I have to keep buying laundry detergent and we can't afford to keep this up." So, he had this baseline sort of preoccupation with cleanliness that had just skyrocketed into this intense, driven obsessionality. And he was staying up all night, not sleeping. In addition, if you went down the criteria for bipolar disorder, you could tick off the fact that this was an acute onset. He had this symptom, this symptom, and this symptom. And in addition, he was psychotic. So, he kept telling his school that he had a girlfriend by the name of Shannon. And he didn't even know anybody by the name of Shannon, but he was convinced that Shannon was in love with him, that they were going to get married. And it was more than just a fantasy. You could not reality test with him. And in fact, eventually he was able to tell me that he heard Shannon talking to him and telling him to do things. So, the good news is I was able to work with the mom to get sufficient history to determine that there had been a clear change from baseline, exaggerated baseline symptoms. He had clear episodes. And the happy news I'll share with you is, we started him on lithium and a touch of risperidone, and he improved. He actually went back to school, was no longer in restraints. And I have to tell you, this is really a true story. So I think it was about 4 years ago now, I heard from him. He sent me an email and he told me that he finally got his driver's license. He graduated from college and he had recently gotten married, and he wanted to let me know that. So that was a very happy outcome. So let's move to schizophrenia. So for those of you who don't know, I actually worked intramural at the NIH for several years and had the pleasure of working with Dr. Judith Rappaport. And I ran an inpatient unit where we brought children from all over the country who had onset of psychosis before the age of 12, and thus qualified as having childhood onset schizophrenia. And again, for those of you who don't know this, we were offering the first clinical trial of clozapine at the time. And so we would fly these children in from all over the country, and they would stay on our inpatient unit, and we, rigorously phenotyped them and did a number of different studies while they were there, including collecting some data on their premorbid history. And up to 55% of these children who had childhood onset schizophrenia had pre-psychotic developmental disorders that had similarities to autism. So, for example, they had language delays, motor development abnormalities, including transient motor stereotypies, and clear deficits in communication and social relatedness. And then, when we diagnosed them, we also looked at whether they had true autism, and we found that 28% of these children with childhood onset schizophrenia had comorbid COS and autism. The other thing that is interesting is that we found that 30% of the children with COS had a first-degree relative with autism. So clearly, in this sample, there was an overlap, and there's a clear sort of genetic overlap as well. All right, so this is work done by Deborah Weisbrot. She published this in 2005. This is part of a journal article that I was a special editor for. But she looked at psychotic symptoms, anxiety, and mood disorders and autism, and found the following in children who were ages 6 to 12 years old. She looked at those with and without autism and tried to capture whether they had anxiety and or psychotic symptoms. What she found was that the psychotic symptom severity correlated with anxiety level in both groups, and that those with autism had an increased rate of both autism and psychotic symptoms. The psychotic symptoms that were only present under extreme stress, she was wondering if their primary diagnosis was actually anxiety and not psychosis. She also underscored that mood disorders can present with psychotic symptoms, and that most epidemiologic studies indicate an increased incidence of mood disorder with or without psychosis in autism. Let me pause for a minute, because one thing I didn't add in the previous couple slides about bipolar disorders, it's important for everybody to know that depending on the study you read, children with bipolar disorder, bipolar 1, anywhere from 16 to 60% have psychotic symptoms as well. If you're looking at adults with bipolar disorder, anywhere from 50 to 70% have psychotic symptoms. So it's important to keep that in mind. All right, so the core symptoms of autism can be mistaken for psychosis. And again, this speaks to the DSM conundrum. Developmental history indicates presence of symptoms stable from early childhood, right? So if the symptoms are stable in a child with autism, that's probably part of their autism. If there's a decline in functioning, then that's a different story, right? The disorganized thought process in autism can be mistaken for psychosis. So they can be disorganized. But if there's a disorganized thought process without a clear history of delusions or hallucinations, then that's probably not psychosis. Sometimes abnormal preoccupations can be labeled as delusions, but a stereotypic preoccupation with something like beanie babies is very different than a fixed false belief. And it's important, this whole notion of a change from baseline is critical. If there's no decline in overall functioning from baseline, then it's more likely that what you're seeing is part of their autism and not a part of a psychotic presentation. All right. So what about it? Is there a comment? Lola? No? Okay. What about the comorbidity of schizophrenia spectrum disorder? So this is what I'll say to you, is that new onset of delusions and or hallucinations, and it's important that the hallucinations are from an external source rather than a thought or their own voice. But if there's new onset of delusions and or hallucinations lasting more than a month, then that's a concern. If there's a disorganization of thought or behavior that is a clear change from baseline, that's notable. If the degree of magical thinking or inability to distinguish fantasy from reality, that is a clear change from baseline, that's important. So for example, my patient with bipolar disorder really thought he didn't just have, you know, a friend, an imaginary friend. He thought Shannon was his girlfriend. Also consider the comorbidity of mood and or anxiety disorders that coincide with the onset of psychotic symptoms. And again, this whole notion of a change from baseline, a significant decline in overall functioning. All right, so let me share some diagnostic rating scales that we use as standardized assessment for autism. For those of you who are child providers, you probably know most of these are gold standard instruments that we use to diagnose autism are really a combination of the Autism Diagnostic Observational Scale and the ADIR. There's also the Social Communication Questionnaire and the Social Responsiveness Scale. In addition, there's the CARS-2, which I don't have in this this table, but the CARS-2 has been validated against the ADOS, and in fact, during the ADOS has to be done in person. And during COVID-19, the whole field had to pivot, trying to figure out how to work up this backlog of kids that were on a waiting list for a diagnosis of autism, and many providers pivoted to using the CARS-2 to do that because it could be done electronically. Now, the problem here, first of all, everybody asks me, how do you diagnose psychosis in a child with autism? And here's the problem for child. And again, I don't know how many of you are neuropsychologists, or psychologists who do testing, but the reality is most of our projective testing in childhood, they're not reliable in terms of diagnosing psychosis below the age of 10. Okay, now, it's not very common to have a child who truly has a psychotic disorder be below the age of 10, but if they really do, our projective tests are inadequate, and it really is a question of getting adequate history and observation. It's an observational kind of diagnosis. Are there rating scales that can be useful? Well, yes. I mean, the positive and negative syndrome scale, which is used in all of the sort of adolescent schizophrenia studies, for example, can be used, but it hasn't been validated in those with autism. That's the problem. Most of our diagnostic instruments that we use in child psychiatry are not validated in this population. But the PANS is a 30-item clinical scale which evaluates general psychopathology, both positive and negative symptoms of psychosis, and each item is rated on a 7-point symptom severity scale ranging from 1 to 7. And I do use this instrument, but clearly you have to have a caretaker available, and mostly using these instruments requires some degree of language capacity on the part of the individual being evaluated. For example, delusions. To be able to describe a complicated internal state, you have to have language. So delusions are difficult to diagnose in a nonverbal child, for example, or adult. I sometimes use the brief psychiatric rating scale. It's a beautiful instrument in child psychiatry. It's one of the most widely used instruments, enabling the clinician to quickly gather information about the possible presence and severity of various psychiatric symptoms, but it's not specific for psychosis. And again, for those who do adult work, I'm sharing some of the child rating scales because they may be more appropriate to use in adults who have autism, given some of the developmental concerns. The Aberrant Behavior Checklist is an interesting checklist. It's validated in the IDD, Intellectual and Developmental Disabilities population, and in autism, and we use it quite frequently clinically. It is the one scale that we use in clinical trials quite frequently. So, for example, one of the domains that we're interested in is irritability. And we use the irritability subscale at baseline and endpoint in clinical trials to see if various agents improve the irritability that we see that's associated with autism. However, there is a lethargy and social withdrawal subscale of the ABC. And, I would argue, and I've used this sometimes clinically, that if there's a change from their baseline lethargy social withdrawal scale, let's say you have a child or adolescent or a young adult who presents to you with severe anxiety at age 15 or 17, and then suddenly you see a decline in functioning, it might be interesting to do the ABC again to see if there's a shift in the lethargy social withdrawal subscale, demonstrating a worsening of their presentation. Now, I'm going to share another scale with you that honestly I don't know a lot about. It was recently published in 2022. It's called the Positive and Negative Syndrome Scale for Schizophrenia, Autism Severity. These authors basically took the PANS, which is the first instrument that I described, and modified it to assess more fully for autistic traits. And it's got interesting psychometric properties, but there's some evidence for the reliability and validity of what is called the PAS for quantifying autism symptom severity transdiagnostically and to identify autistic phenotypes in schizophrenia. We have to wait for more work to be done on this measure, but it shouldn't be used to diagnose autism in people with schizophrenia. It's just a way of quantifying an autism phenotype in those who have schizophrenia. All right, so again, the autism schizophrenia conundrum. On the left, you have what we see in autism. On the right, you have what we see in schizophrenia. In autism, we see a decrease in nonverbal communication, decreased reciprocity, stereotype language, self-dialoguing, which, they sometimes talk to themselves in script. Sometimes they repeat, the phrases from their favorite cartoon. And some people mistake that as being hallucinatory. They have decreased spontaneous play, preoccupations, stereotypies, and decreased social communication. On the right here, we see what we see in schizophrenia: social withdrawal, affective flattening, disorganized speech, auditory hallucinations, disorganized behavior, delusions, I have catatonia over here, but unfortunately, we can sometimes see catatonia in autism and negative symptoms. All right. So Starling and Dosator wrote in 2009 that thought disorder and bizarre behavior are totally unreliable due to the fact that they are also core in PDD symptoms. Okay, PDD also is autism. That's the old term that we used to use. Delusions, they claimed, are more reliable, but cautiously useful, as an unusual worldview and idiosyncratic obsessions are also seen commonly in autism. Auditory hallucinations need to be differentiated from self-talk or pseudo hallucinations, and they highlighted in 2009, and anybody who's doing this work will highlight that delusions and hallucinations together are the hallmark of psychosis, and it needs to be accompanied by a decline in functioning. So let's move.
Dr. Frazier, actually, there's a question in the chat that I think really related to that point. So Albert Wen says there's a paper by Elizabeth Milne in 2017 comparing perceptual disturbances and hallucinations in autism spectrum versus neurotypical populations, and saw that the autism spectrum population had more perceptual disturbances. So is this sort of anomalous perception something that you see in autism and in a way that's different from psychosis?
Yeah, and that point is well taken. So the anomalous perception often is rooted in sort of a sensory integration concerns. And there is a heightened anomalous perception in that regard. So people with autism have a heightened sensitivity to sound, light, texture, but that is different than a hallucination. A hallucination, and again, was another recent paper that tried to synthesize, I think it was in 2019, information from a variety of sources, and a hallucination really is more, an auditory phenomenon that is external to the individual, not internal. It's not self-dialogue. It's not hypersensitivity to real stimuli. It's responding to external stimuli or responding to something that actually does not exist. I don't know if that's helpful.
Yeah, no, that's really interesting. Thank you. I think, just as you're talking of how in the more clinical high risk stage of things, we often think of that sensitivity to stimuli as a kind of preempting of more frank types of hallucinations. So that it's interesting to hear that connection.
Yeah, and it's also interesting, I didn't mention this, there's a recent article, kind of a meta-analysis of some of the prodromal samples, and I didn't put in the slide deck, but I think that, and I apologize if I have this statistic somewhat inaccurate, but my memory is that they looked at those with clinical high risk prodrome and found that about 11.6% actually had autism. And that paper, as well as that recent compilation of the literature, highlights the fact that yes, the autistic population is more, quite prevalent in the clinical high risk, but more work needs to be done on looking at that transition to psychosis in that population. So,
yeah, very interesting. Thank you.
Yeah. So let me talk a little bit about what we know about treatment for autism disorders. Obviously, this is a neurodevelopmental disorder. Pardon me, that's lifelong. And these individuals, happily often are supported nicely within the confines of their school age years up until they graduate from high school. But the treatment's multimodal. I often say it takes a village You know, behavioral components to it, educational components, and, you know, in many pharmacologic components. And it's just really important to target the appropriate developmental stage of the individual and provide early assessment and intervention, as well as ongoing therapy. There are other, these are mainstays of treatments for autism. Applied behavioral analysis is actually has the most evidence basis behind it. Many other types of autism based therapies are actually based upon ABA, but there's also the CERTS model, and there are other models. Many require speech and language therapy and social skills group. Other common additional treatments involve occupational therapy, physical therapy, cognitive behavioral therapy, other types of behavioral interventions. And there are other things that are quite helpful, like, you know, activities like swimming, music therapy, massage, animal therapy, like therapeutic horseback riding and service dogs. And, you know, some families really claim dietary interventions are helpful. There's not a good evidence basis for that necessarily, but you know, I like to treat everybody as an individual. And if, you know, somebody's lactose intolerant, of course, they need to be on the appropriate diet. One example of that is just quickly, I had a kiddo who had actually nonverbal, he was a young adult at the time, who developed new onset seizures, and his neurologist put him on Depakote, which when he was put on Depakote, he started bolting and eloping and aggressing, and he also started drinking gallons of milk and eating bars of butter. And we eventually got him off the Depakote onto another anticonvulsant, and he settled down, but we also did a workup for lactose intolerance, and it turns out he was lactose intolerant. And it's probably wasn't the Depakote at all that was causing the aggression. I think it made him crave the food and created GI discomfort, and then he started aggressing. And once we got him on a lactose free diet, he settled down. So the target of medication in autism, well, core features of autism are impaired social interaction and communication, repetitive behavior, and restricted interest. But unfortunately, we have no medications that are FDA approved to treat the core features of autism. None. Usually we prescribe medications for autism for specific behavioral problems like aggression, irritability, self-injury, hyperactivity, anxiety, and sleep. We have 2 agents that are FDA approved for irritability associated with autism. So risperidone is approved to treat irritability associated with autism, it is not FDA approved to treat autism. So this has been approved for children and adolescents between the age of 5 and 16 years. And aripiprazole is FDA approved, again, to treat irritability that's associated with autism in children and adolescents between the ages of 6 and 17 years. So what about the treatments for autism and psychosis? There are a variety of psychosocial and educational interventions that support children who have COS, or childhood onset schizophrenia, and children with autism. And they exist to address core social deficits, communication deficits and behavior, and the associated developmental and medical conditions. Atypical antipsychotics are the mainstay of pharmacotherapy for schizophrenia at any age, and they are also used to manage certain symptoms associated with autism, particularly irritability. Now I'm going to share some just data across child and adult studies, because I think it's important for those of you, all of you, to have a developmental lens and to know the following, that children are not just small adults, right? Things change in the body as you age, right? The number of neurotransmitters in the brain change, the liver enzyme capacity shifts, the amount of adipose tissue shifts. And, we've done a number of studies. The effect size is a measure of impact of a certain drug on a condition. And, we aim for an effect size of 0.5. And this is looking at the mood stabilizer clinical trials using the Young Mania Rating Scale as an outcome measure, looking at youth and adults. And if you look down here, all of these mood stabilizers that we typically use to treat bipolar disorder are less effective in across the studies in youth than in adults, right? So there's only one agent, interestingly, that had an effect size above 0.5, and that was topiramate. And for those of you who know psychopharm in this area, you know that the adult study was negative. And in fact, they had to stop the adult study prematurely because they were having such poor results. But if you look at the adult studies using mood stabilizers, look at this. For Depakote, lithium, Tegretol. So the effect sizes are much better using mood stabilizers in the adult population with bipolar disorder. Now let's look at the same thing using atypical antipsychotics. Here we have youth on this side. Again, an effect size above 0.5 is robust. And you look down all these atypicals on the left-hand column, and Haldol's in here too. But if you round up ziprasidone to 0.5, basically they're robustly effective acutely for bipolar disorder in youth. Conversely, look at the adult clinical trials and their effect sizes. I mean, you've got some signals here that are nice, with olanzapine close to 0.5, quetiapine 0.52, risperidone 0.71, and Haldol 0.62. So what about FDA approved treatments for pediatric bipolar disorder? Again, we've got some huge needs in the child field. We have very little armamentarium to treat acute bipolar depression, and we have very little data that tells us good information on longer term treatments. Happily for the adult providers who are psychopharmacologists, we know a little bit more. And then, well, what about efficacy of atypicals in adolescent schizophrenia? So there have been a number of studies done happily, and they also show some signal, aripiprazole, paliperidone, comparison of paliperidone versus aripiprazole, lorazepam, risperidone, olanzapine, quetiapine. This is a very detailed slide, but needless to say, they're all effective. And more importantly, I think that these meta-analyses are most informative for child providers, but also, for transition age youth. And I would argue for adults with autism, because people with autism are vulnerable and their brains are wired a little differently. And it's very clear that people with autism in general require slightly lower doses and are more sensitive in terms of the side effects on most agents. So the common lore in the whole field of autism is to start medications low and go slow. So this is a systematic review and a network analysis of acute antipsychotic treatment in youth. And these are youth with schizophrenia. These are not youth with schizophrenia and autism. Unfortunately, we have almost no data on the treatment of the comorbid presentation. So what we know here as, this meta-analysis compared the efficacy and safety of antipsychotics in youth with early onset schizophrenia. And what I mean by early onset schizophrenia is onset of symptoms below the age of 18. They looked at 12 studies. Each one was of a duration of 6 to 12 weeks. It included 2,158 youth between the ages of 8 and 19 years, and 8 antipsychotics were involved, including molendone. I was involved in the treatment of early onset schizophrenia study several years ago now, and molendone was used as our comparator there. And what they found was there's comparable efficacy among antipsychotics, except for ziprasidone, which was inferior, and they had unclear results with acenipine. Aripiprazole and quetiapine had the best tolerability. So here's another meta-analysis, which I'll share with you, a network meta-analysis. This was published more recently in 2018 by Cruz et al. And in terms of efficacy, again, they found no substantial differences between antipsychotics except clozapine for treatment-resistant patients. And like the other network meta-analysis, ziprasidone was not efficacious. It's not recommended due to lack of superiority to placebo. In terms of safety, olanzapine is not a good choice due to significant weight gain. Clozapine and quetiapine increase weight, and only molendone, lorazepam, and ziprasidone may be more weight neutral. And I phrase it that way because none of these agents are benign. Most drugs are sedating and even comparably safe antipsychotics, i.e. aripiprazole and quetiapine, may produce EPS, so please know that. Risperidone, haloperidone, olanzapine, and paliperidone have a high propensity for prolactin increase. And the conclusion of this particular network meta-analysis is because there are few efficacy differences between drugs, treatment should absolutely be based on and guided by side effect profile of the agents. All right, just a few more slides and then we can have some questions. But omega-3s, we've got some evidence that they're helpful in treating ADHD, depression, and adjunctive for bipolar, as well as prodrome. There is an open label study in autism where they found improvement in all subscales on the SRS and the social and attention problem syndrome scale on the CBCL. A double-blind study in children with autism between the ages of 2 and 5 was negative, unfortunately. I put ECT in here because, of course, we use that for refractory psychosis as well as clozapine. Clozapine is probably the best agent. There's objective and confirmatory data available in adults for sure, but they're sparse in youth. The average response rates are about 80% for catatonia, 80% for mania, 63% for depression, and 42% for schizophrenia. That's based on adult literature. The average ratio for adult to minor use is 65:1. There's no national standard with regards to minimum age. For example, it's age 16 in Texas and Colorado, 14 in Tennessee, and 12 in California. It is safe and beneficial with high response rates, but more training is needed so that physicians are educated about ECT. All right, so I'm just going to focus on this a bit. Again, how do you diagnose schizophrenia or psychosis in kids or young adults or adults? Well, it's observational and historical. Again, it's a clear change from baseline. There can be cognitive impact, and it has to include delusions and hallucinations. DMH has often asked me, well, how do you know what the real dysfunction is due to, Dr. Frazier? If they have autism and schizophrenia, what is impairing their functioning? And the good news is most children who grew up with autism have, assessments under their belt. And the majority of children, adolescents, young adults have been on an IEP in their school system. They have repeated GAF scores, repeated neuropsych testing, and you can actually create a timeline where you look at what happens in the neuropsych testing prior to the onset of the serious mental illness, and then afterwards, once the child is treated for his psychosis. So this is based on a true case. I won't belabor details about the case, but basically this young man was diagnosed at age 3.5 with autism. He had repeated neuropsych testing prior to the onset of his psychosis, which occurred at age 12. We knew that his average IQ score was average to above average in terms of neurocognition. His GAF score was 61. Onset of psychosis at age 12, was really seriously ill, 3 hospitalizations, multiple medications, finally got stabilized. And at age 17, his GAF score had gone down to 41, and his neuropsych profile indicated a range of functioning from very low to average. And in this case, it's clear to me that the enduring problems with this young man were as a direct result of his serious mental illness. So takeaway points for you. Autism and schizophrenia may present as 2 separate disorders that need to be differentiated. Again, it's not uncommon for me to get consulted to, Dr. Frazier, does this young man have schizophrenia, schizotypal personality disorder? Is this autism? Is it some combination thereof? They can present as comorbid conditions. What differentiates between autism and schizophrenia and determines if a youth with ASD has psychosis are, number 1, a change from baseline with a decline in functioning, and number 2, the onset of delusions and hallucinations. Some individuals may have both disorders, which, as I've described, has important implications when thinking about a treatment plan. So I just want to give a shout out to all the people who work with me, both clinically and in my research lab. They keep me safe and off the streets at night. And I want to thank you for your attention. And let's wrap up with any questions that you might have.
Thank you so much, Dr. Frazier. We've had some really rich, excellent discussion and questions in the chat. So I apologize if I can't get to everybody. Their most recent questions, so 2 kind of related. So Tova Cohen is asking, what about for individuals over 18 years old who are presenting for psychosis, but are suspected to have a comorbid undiagnosed autism? So can you assess that while they're experiencing symptoms of psychosis? And I'll tie that in with what Carrie from the First Hope program asked before, which is, how do you accurately diagnose between ASD and psychosis when you don't have access to accurate historical data?
Yeah, so let me try the first question. So I get asked a lot, as you might imagine, young adults may not have had adequate access to care when they were younger. I think things are improving now, so it's more likely that the kiddos who develop psychosis at 18 will have a prior diagnosis, but we still have those who didn't have the benefits of access to care. And I've seen those adults, they get sent to me, and sometimes they're still actively psychotic. So again, what I try to do, if there's any prior information, is to create a timeline. And it is hard to make a diagnosis of autism while somebody is actively psychotic. So it's really important for the psychosis to be treated in those adults first. If you're still entertaining that there's a comorbid autism diagnosis, because once they're more stable, then you can do an ADOS or an ADIR and get a full, diagnostic look at them in terms of those developmental delays. And I would argue it's critical to do that, because even as adults, we'd like to say in child psychiatry, early intervention is critical, and it is. But even if there's an adult who has a comorbid autism presentation, they could really benefit from those autism-specific services. And then if you don't have the luxury of historical information, which does occur, for example, if a child has been in the Department of Children and Families, sometimes records get lost, or you may just have somebody who is homeless and doesn't have a family and there are no prior records. That's harder. And I don't have a good answer other than to argue that this is a historical and observational sort of diagnostic dilemma. And I think it's critical. First of all, if they present, they're psychotic, there's no question. The first thing is to get them stable and less anxious and less psychotic, and so that they're able to heal. And then once they're more stable, to relook at whether there's a possible comorbid autism diagnosis. And, I would encourage you, if you don't have a colleague who has expertise in diagnosing autism, that you try and find somebody in your community to help you tease that out.
And I see Kesh has his hand raised.
Yeah,
Yes.
thank you. Thank you, Dr. Fraser, for a wonderful overview. I had a question from the front, cutting edge. Are there any biomarkers that could distinguish between a primary autism spectrum disorder versus primarily a psychosis spectrum disorder? There is this literature on N170 evoked response potential to faces. What do you think of that? Also, autism is highly heritable, and so is schizophrenia. Would polygene risk scores be of any value in eventually in the differential diagnosis?
Yeah, well, because I think this is such an interesting field, and it really is a rich area of research. I do think there's some value to looking more fully at the evoked potential concept. Right now there's no biomarker, to my knowledge, that really adequately differentiates between the two, but there are a lot of potential promising ones, and I do think the evoked potential is one. And I love the idea of the polygenic risk score, actually. But I would encourage you, Kesh, if you if you guys can take this on, that you really should, because it would be such a valuable contribution to the field.
Thank you. Appreciate
I can also bring attention to another topic that has been brought up, I think, a few times in the chat, is how to best be communicating with crisis responders. So Maureen Nickerson says, often our crisis responders are not detaining ASD clients for psychiatric treatment because they assume that the behaviors are only from ASD. So how can we better communicate and advocate for clients who have comorbid serious mental illness and autism spectrum in these kinds of crisis situations?
Is this Noreen who asked this? Noreen,
yes.
Are you from Massachusetts?
No, I'm from Washington State.
Noreen, okay. Okay. Wow. Well, this is a huge problem. And if you heard the introduction, it's something that I've taken on by storm in the state of Massachusetts.
I would like to take it on by storm.
Well, let's have a private conversation, and I can tell you how we made this happen in our state. We still have quite a bit of work to do, but I think we are sort of at the cutting edge of this right now. I'll tell you just briefly what we've done, but it's still not sufficient. We were able to leverage some money through our EOHHS during the pandemic to take this on. We launched something called the MPAP Autism and IDD program, which is meant to support our mobile crisis intervention teams and our emergency service providers to better serve individuals with autism and intellectual disabilities during times of a behavioral health crisis. And unfortunately, we only go up to age 26. So it's, youth, adolescents, and transition age. I do hope we can expand to adults as well. But needless to say, I mean, your average MCI provider at the front line feels ill-equipped to serve these populations because they've not had sufficient training or exposure. And we're using this platform to help educate our frontline providers how to better serve this population and keep them out of the emergency room and out of the hospital. Happily, we've had quite an impact. We've decreased the amount of boarders in our emergency rooms by 35%. But it still wasn't enough. And we've now augmented our support to the MCI providers by rolling out an ECHO autism crisis care educational platform across the state. And that has taken on a life of its own in a very positive way. But I'd be happy to talk to you, Maureen, offline further about how we made that happen. And
I would really, really appreciate that. I have some other teammates here I think we would like to take that on. So do you have your email in this where I can contact you later?
I don't, but Kelsey, can you share my email with Maureen?
Yeah, we can post it in the chat.
Okay.
Go find it.
Great.
So another question here. So what kinds of specific questions do you recommend to best be differentiating autism and psychosis in an initial clinical assessment?
Okay, so some of this depends on the age of the person, the mental age of the person, their verbal ability. Again, as I was saying, it's more challenging if somebody's nonverbal to get the information you need, and some of that has to be rooted in observation. You're not going to get at the delusional material in a nonverbal autistic adult or child, for that matter, because that requires verbal capacity. But you can determine if there's a decline in functioning, and you can determine whether they appear internally preoccupied and appear to be responding to hallucinatory phenomenon. So, for example, if you have a teenager who never used to do the following and now they're doing the following, it is a concern that there might be a psychotic process going on. So, for example, if you have a nonverbal teen who suddenly starts staring off into space or starts mouthing words to somebody that's not in the environment, or covering their eyes or their ears when there's no auditory or visual stimuli that would warrant that would be a concern. I would also argue that for anybody who has a new onset of what appears to be psychotic disorder, whether it's adult or child, that person warrants a full medical workup, because the comorbidity of medical concerns in those with autism also is much higher. I didn't share those slides with you, but they're known to have much higher rates of GI concerns, seizure disorders, asthma, a variety of different things that could be confusing. Sometimes it's a medical condition that drives abnormal behavior. And obviously, if it's a medical condition that's driving aberrant behavior, you have to treat the driver. You have to treat the medical condition. That doesn't necessarily warrant antipsychotics. Yeah. Some of the questions I ask. All right. So I'm a child psychiatrist. I also see adults. If you're trying to determine if they have a delusion versus fantasy, sometimes it does take pushing, especially with, I'm talking about a verbal patient, and say, look, like with my patient who had bipolar, I said, let's call him Keith. I said, Keith, do you really believe, tell me about Shannon, where does she live? Is she talking to you right now? Has your mom ever met Shannon? Because he told me she was a student in his school. She wasn't a student in his school. So the more details you get about the sort of the depth of the material, the more you can sort out truth from fact. Sometimes with kids with autism, for example, they will say, oh, I have this friend named Henry, and he talks to me and keeps, and he keeps me company. And you sort of ask, you can press them sometimes to say, is Henry real? Is Henry a real person? And just press them on that. And I say, often they'll say no. He's made up in my mind, and I talk to him. He keeps me company. Sometimes with kids, and I found this true with adults with lower IQ, I actually tell stories in displacement. All right, this works really well with latency age kids, like at age 10 or something. But again, you have to look at your client, understand not only their chronological age, but their mental age. And so I will say, let's say the patient is Matthew. I'll say, and let's say the patient is 10. I'll say, the other day I met Mikey, and he was 9.5. And you know what he told me? And I would take material that was supplied by parents or the provider who was referring for a consult, and I say, he told me sometimes he hears witches in the woods talking to him. And then it's really fun in child psychiatry because you can tell these stories. But again, I would say to adult providers, if they have a mental age of 10, you can use the same technique, talk in displacement. And then sometimes if you talk in displacement, it gets them to calm down, and they can say, really? That happened to me too. And so you can really elicit material by telling a story about their symptoms, but making it about somebody else. So those are a couple of techniques I use. I don't know if that's helpful, but it certainly is helpful for me clinically.
Yeah, absolutely. So Sabrina had asked, just as a follow-up to that, so in that example with the girlfriend, if that's non-distressing to the person, is that something that you would consider psychosis? So thinking of imaginary friends as being kind of a developmentally appropriate experience, at what point does that kind of shift over into the psychosis spectrum?
Yeah,
and that might be a complex question.
It is a complex question. And what I would say to you, for those on the spectrum, delusions are not necessarily disturbing. So the issue really is it a fixed false belief? And can you get them to reality test around that? And if you cannot, then it's more on the delusional side of things.
So in the case where they're self-identifying this as an imaginary friend, that is not so much a fixed false belief. Typically,
yeah, but sometimes those kids can tip over into delusion. So again, you have to look at the whole picture, which is there a decline in functioning? Are they totally preoccupied with this imaginary friend to the exclusion of being able to reality test? But really, the sine qua non of psychosis is that hallucinatory experience.
Great. And I think we have time for one last question. I know there's so much more depth we can go into in all of this, but I think really a practical one to end on. Laura Sykes says, or is asking about the best place, in your opinion, for these kids to land when they have a true comorbid ASD and psychosis. So, we have our resources for psychosis through the CSC programs. The autism spectrum providers are often hesitant to be working with psychosis. So what do you best recommend for that?
Welcome to my world. Yeah. I mean, there's a clear divide between developmental behavioral pediatricians and child neurologists who are wonderful at monitoring the developmental issues, but they're not comfortable with the comorbid psychiatric concerns. And I would argue vice versa. That's why this webinar is important. Most mental health providers have not been trained in autism, even child psychiatrists, right? And we need to close that gap. I would say that for I think you have to look long and hard at what's available in your community, because I know we have people from out of state. There aren't many facilities that do well by these folks. There are some therapeutic schools, so for example, in our state, a few come to mind. The League School does a nice job. The Gifford School for little ones, Community Therapeutic Day School, the Arlington School and Teenagers, Victor School. There are others. In terms of hospitals, it's there aren't that many. It used to be that we would try and send folks to the program in Maine, and sometimes Bradley Hospital, where I did my child training. They do a fine job there. But more recently, in our state, DMH has taken this on by storm, and they're creating a couple of CBATs right now, and they have funded a couple of inpatient units. One of them that I think will be promising is the one at Cambridge Health Alliance. So, and I don't have good advice for folks who are out of state, other than you have to really do your homework, because it's not easy. And I'm sorry for that, but I do believe as this population continues to increase in prevalence, we're going to have better facilities and have people educated more widely on how best to serve this population.
Well, then I will end on the note of saying thank you for what you're doing right now for helping kind of expand that knowledge in the workforce. I think this is not the last kind of conversations that we'll have about it. So we really appreciate having your expertise on this.
Yeah, and it's so good to see everybody. And thank you for joining me. And I hope you have a good afternoon.
Yeah, have a good Friday, everyone.
Thank you.